My name is Charlotte. I'm Chief Executive of National Voices. I'm going to be facilitating today's hour we've got together. The way this works is that we have a session in the morning like this with speakers from all walks of life. And in the afternoon, we have workshops that are led by National Voices members. National Voices is our coalition of health and care charities. We've got about 170 members. Some of those are the really large names you will have heard of: Alzheimer's Society, Diabetes UK, and a lot of them are charities you might not have heard of, doing really important work with rare conditions or in local communities. And they are leading workshops in the afternoons. We have really great speakers today. I don't know whether you want to, am I showing the slides? Are the slides there? Not sure. Laura, are we seeing slides? Okay, if you show the next slide, there we go. We've got an action-packed agenda with some great speakers. Helen is with us today. Helen is our brand new chair of National Voices, and she will extend her welcome to all of you and set the tone a bit for what we're trying to achieve today. And then we've got Sandra, who joins us talking about her experience, which she both acquired from working and from living, like most of us. We've got Professor Sir Michael Marmot, who is going to talk about his groundbreaking work he's been pursuing for the last 10 years. Will update us on where inequalities have got to, and will reflect on what we might need to do if we want to build back fairer. And Bibby from the Health Foundation will talk about really important work they're doing there to understand how we could talk differently about how health actually comes about in people's lives, and how illness comes about in people's lives, and how that's unequal. And they're doing really interesting work on how we need to reframe how we speak about these issues if we want to be heard better. Before we kick off with this really important agenda, I want to talk about the technology briefly. And anyone who knows me knows that this gives me more anxiety than the really ambitious stuff we're trying to do. But I'm relying on the capabilities of a really good team who've made this all happen. Because if it was relying on my capabilities, we'd be stuck. So this is a quite large group of people. So we have two ways to engage on the go. There is a chat where you can all talk to each other. Please introduce yourselves in the chat. It would be super helpful if you could say in one sentence where you're from as well. And you can, pick up points people are making. And we have, in our previous webinar series, really great experiences of there being a lot of rich insight in the chat. And it also is quite nicely democratic, because everybody's just on the chat and there's no stage on which people are elevated. And then we have the Q&A function. So you can see those little buttons at the bottom of your screen. There's a Q&A and there's a chat function. And the Q&A is where you can ask a question to the panel, to those speakers I've just mentioned. And we have a couple of colleagues from National Voices, both on the chat, to moderate and to pick up interesting points, and on the Q&A, and they will try to make sure that we get through as many questions as we can, and maybe group them a bit so that we can reflect what's going through your minds. We're also trying to make this conference as accessible as we can. So I will do my best to try to read out what emerges on slides so that you can hear it if you can't see it. We have a sign language interpreter on the call, Richard, who you should be able to see if that is something that works for you. And we have got closed captions going on. So again, at the bottom of your screen, there's a little CC, which stands for closed caption. If you click on that, you can see in writing what we are all saying, which I think is just magical. And you can change that in the way that it works best for you, different colors, different fonts, and so on. If there's any other problems you have with accessibility, or something doesn't quite work for you, technology fails, please reach out to us. You've got, I think, Rosie's email address. And which email address are we asking people to email or contact or chat to? Can someone just remind me? never mind. Okay, let me just see whether I've said all the things I needed to say.
Do email info@nationalvoices.org.uk if you're experiencing any problems.
info@nationalvoices.org.uk. Wonderful. Let me just see whether I've said all the things I needed to say. I think I have. And now, slightly unfairly, I hand over to Helen, who's going to say the interesting things and also introduce our first speaker, Sandra. Over to you, Helen. You're on mute.
Somebody had to be the first, didn't they? So yeah, may as well be me. So thank you, Charlotte, and thank you to everyone who's joined us this morning from across the country. I've been looking at the introductions coming in, and I think one great thing about this way of working is that we don't feel as if we're dragging everyone to London. The series of discussions we're going to be holding over the next 4 Tuesdays are incredibly important to us in National Voices. All the evidence shows us that inequalities have a massive impact on disease burden. People who are poorer, people who have a different skin colour, people who have disabilities are all likely to live shorter and less healthy lives. And we think that's wrong, and we're not going to tolerate it anymore. National Voices are committed to working with partners across the voluntary and statutory sectors to improve health outcomes, not just by fixing health services, although that's important, but also by getting upstream and learning what can be done and what must be done to tackle a range of determinants of ill health. This is not about changing who people are. It's about ensuring that whoever you are, you have the best possible opportunities in life. We're so far from having the answers ourselves. And we know that at present, at least in our team and as a group of trustees, we are very largely white, middle class and able. And it's really important to us that we learn how to be good allies and to approach these discussions with humility. We're so grateful to all the experts by experience who are going to be giving us their time over the next 4 weeks to help us learn. I also want to thank everyone else who's making these events possible, our partners at the Health Foundation and PPL, all the National Voices members who are running sessions, and the whole National Voices team. And I'm looking forward to an excellent and really action-orientated 4 weeks. I think, as Charlotte says, it's not good enough just to describe the problem. We've really got to get into what are we going to do about this now. And to kick that off, I'm really delighted now to introduce Sandra Jayacodi. Sandra is a former solicitor. She supports asylum seekers. She was forced to retire due to ill health, and she now works on inclusion for people in communities in many forums. She's an improvement fellow for the NIHR. She works in research. Most importantly, of course, she is an expert by experience herself, and she's going to be talking to us now about what poverty and health inequity mean to her. So welcome, Sandra, and over to you.
Good morning, everyone. Thank you, Helen, for the introduction. I'm going to share with you what poverty and health inequities mean to me. Health inequities means something different for each individual based on complex factors surrounding the individual's life. It's not a blanket term. Everyone will have their own story to tell about what we know as health inequities. And most people, including myself, won't have been using these terms loosely. I was a solicitor before I was diagnosed with a long-term mental illness and signed off as unfit to work. It was only lately when I started getting involved in patient and public involvement and engagement work that I came across the terminology health inequities. However, I did not totally understand its importance or its significance. To me now, health inequities are factors that stops one from accessing or hinder someone from accessing and receiving good health care. Health inequities to me also means someone not able to accessing the services because of the language barrier. When I was a solicitor, I saw a lot of asylum seekers, migrants who are coming from different countries. It was very difficult for them to register with their general GPs because they could not speak the language. So their healthcare was delayed. The environment we live in or work in could also be a contributing factor. When I was a trainee solicitor, my desk was in a room which was moldy and damp. As a result of that, my asthma became worse. I had to make a difficult choice of leaving that place of traineeship. Then there are areas where we live in that can also determine the kind of healthcare that we receive. Statistics show that people living in richer areas are healthier and live longer than those living in poorer areas. To me, another meaning of health inequities was the stigma that was attached to mental health. My own mental health stigma prevented me from seeking early treatment and care. Once I was diagnosed and was in care, I was very fearful of what the doctors would take my physical health seriously or not. I was wondering whether they may think I was making them all up. So, what is the relationship between poverty and healthcare? Most of us can relate to poverty and poor healthcare, but I also learned that poverty can lead to, that poor healthcare can lead to poverty. For example, I was forced to leave my job following my diagnosis of long-term mental illness. People don't make bad choices. This choice was made for me, and it led to an incredibly significant drop in income, which means making changes to my lifestyle. These changes were difficult and unfavorable to my overall health. We also talk about equality and equal treatment, but what's more important is about understanding people as individuals that matters. Their life experiences as a whole, including cultural differences. I want to share with you something what my father said when I was growing up. He would always tell us not to question the doctors or be upset with them, especially if they were going to operate on you. He feared that doctors would treat you less favorably. He would also tell us that the doctors are the experts, therefore we should listen to them. This creates an imbalance of power where people aren't equipped to challenge the care we are offered. I can now understand why it took me an exceptionally long time to build the courage to ask my general practitioner for a referral to a consultant, or even speak to my psychiatrist about reducing or reviewing my medication. I would like to see a two-way communication between healthcare providers and the patients, a communication that empowers people to ask questions, healthcare and social care providers to sit beside them to understand what they are going through. I would like to see patient-centered care that asks and addresses the health inequities. For instance, I should not be just treated for the illness without taking into account everything about my personal experience, like the environment I live in, my financial and social factors, any extra support that I may need. This will all help with my recovery. The COVID-19 pandemic highlighted that ethnic minority groups who live in urban, overcrowded, and more deprived communities and in lower paid jobs carry a high risk of exposure to COVID-19. Being someone from the South Asian community, this pandemic has really helped me to understand more about poverty and health inequities. To sum up, for me, poverty and health inequities are avoidable. They do not occur randomly or by chance. They are determined by circumstances that we live in, which are sometimes beyond an individual's control and can limit their chances to live healthy and live longer. This conference is a great opportunity for us to come together and to address these issues. Thank you.
Thank you so much, Sandra. That was really good to hear and hard to hear as well. What I'm taking away from that is it's not just one thing, isn't it? It's like culture and poverty and beliefs and stigma, and those things aren't just either causes or outcomes. They also get into these circular relationships where poverty can cause ill health, but ill health can also cause poverty. Yeah. And one thing that I think you brought out very clearly is a reluctance to challenge or a lack of confidence to ask for better, which is something I know from talking to a lot of colleagues at NHS England right now, is really showing up in the numbers. We think this is just a personal thing, but actually when you look at that and trends across people returning to the NHS after the first wave of the pandemic, people using emergency healthcare, people using specialist healthcare, that is really showing up in the numbers. And we need to do something about that, because those with the highest burden of ill health end up being least likely to get help. We want to now do something, and we will obviously draw on Sandra's insight and also Sir Michael's and Joe later. Before I hand over to Sir Michael, I want to get you all out of your chairs and engaged with an interactive activity. If that gives you a bit of anxiety, join the club. My colleague Laura, who is our tech wizard, is now going to share with you a link in the chat. And that is a chat link to something called the Mentee Meter. And that allows you all to tell us what you think should be our priorities for this conference. You can choose 3 words, and we will then, whilst we listen to Sir Michael, turn these 3 words, or the technology will, I think, turn this into a word cloud for us. So please do click on that link. It's popping up in the chat right now. Fill in those 3 words, have a little think. What do you think we need to do? What should be our priorities for this conference? And then we can see what most people believe we need to achieve over the course of this month. Right. I trust you can do 2 things at the same time, because that's one thing we have thoroughly learned in the last 12 months. And I will therefore now hand over to Sir Michael. Over to you.
Thank you. I called my report in December 2020, Build Back Fairer. The argument was that we should not go back to the status quo of where we were before the pandemic. The report that I produced with the support of the Health Foundation in February 2020, Health Equity in England, the Marmot Review 10 years on, documented 3 unwelcome features of health in Britain. Firstly, a slowdown in improvement in life expectancy, which was more marked in England and the UK than in any other rich country except the United States and Iceland. Second, an increase in health inequalities. And thirdly, life expectancy was falling for the poorest people outside London. And I listened closely to what Sandra was saying, but this is not primarily a health care issue. It's a health issue related to the social determinants of health. And then the pandemic struck, we saw marked inequalities, and we had the worst management of the pandemic in Europe, the highest excess mortality of any country in Europe. We had even a higher excess mortality than the United States of America, which most people would agree had a disastrous management of the pandemic. And I asked myself, what's the link between where we were before the pandemic and our poor management of the pandemic? And my speculation is the link works in 4 ways. Firstly, the quality of governance and political culture. Second, the increase in social and economic inequalities. Thirdly, we were not very healthy coming into the pandemic. And fourth, the disinvestment in public services, the regressive cuts to spending by local government, the squeezing of the National Health Service. So my Build Back Fairer report addresses these, and I urge you to read it. We say that we should put equity of health and well-being at the heart of all policy. And I give a series of specific recommendations related to early child development, education, employment and working conditions, having enough money to live on, and healthy and sustainable places to live and work, and the social determinants of lifestyle and prevention. But I want to talk about something else related to Build Back Fairer, which is assumptions about who we are. the decade from the 2010 resurrected the language of the 19th century of the deserving and undeserving, the undeserving poor. We could have been in the early Victorian age in talking about the undeserving poor. Remember shirkers and strivers? This Manichaean divide between shirkers, the undeserving poor, and strivers, the so-called hardworking families. What an appalling state of affairs. What an appalling assumption about who we are, them and us the decent ones and them the undeserving. Absolutely appalling. Building Back Fairer has got to change that language and that understanding. And that understanding spreads to blaming people for their own illness, saying it's your fault. You dish up poor food for your family. It's your fault. We've amplified the findings from the Food Foundation that for people in the bottom 10% of household income to follow the healthy eating advice, they would spend 74% of their income on food. It's not their fault. It's the poverty's fault. And we know that the majority of people below the minimum income threshold in poverty are in households where at least one adult is working. These people are not lazy, they're not feckless, they're not irresponsible, they're poorly paid. Second, there's an assumption that people are cheats. So the welfare system has to be brutal, uncaring. The first time I heard Edinburgh GPs say they had set up a special clinic for the mental illness consequences of experiences with the welfare system. Universal credit damages people's health. And it damages people's health because the assumption is that everyone's a cheat. And there's a further assumption, which is, as John Kenneth Galbraith pointed out a generation ago, that the rich aren't working because they have too little money, so lower the top rate of tax, give incentives for the rich to get richer, and the poor aren't working because they have too much money, so make the poor poorer. And that's what we did. We assumed the rich need to get richer and the poor need to get poorer to fix the problems in society. We have to change that assumption.
So Michael, I love the passion. Do you think you could wrap it up in the next 2 minutes?
And the evidence is absolutely vital. So we need to change our assumptions, but the evidence is absolutely vital. So, for example, the late John Hills showed that the welfare state, far from being the refuge for the scroungers, actually benefits the rich as much as it benefits the poor, what with pensions, subsidies to universities and the like. So the evidence should actually help us change these assumptions. So Building Back Fairer has got to deal with the whole issue of who we are, our assumptions about people, getting rid of the them and us mentality, and actually creating the conditions for everybody to lead lives of dignity and enjoy better health as a result.
Thank you so much, Sir Michael. I'm sure you've talked about this hundreds of times by now, and it's just so wonderful to hear you still bring your heart to this, because that is what is required. We're not going to resolve this just by swapping statistics. I think we need to also bring some righteous anger, and it's really great to see that people as learned as you access that. It's caused a lot of noise on the chat. People are, responding very strongly to how you frame it, and it's really great to sort of hear that challenge, that we need to challenge how we think about these things and not just fiddle around with, you know, percentages here or there. Before we move on to Bibby's talk, who will talk exactly about that, how can we change how we think and speak about these things? I wonder whether Laura could reveal the word cloud you have all collectively created, which will show, can you make that a bit bigger? Because the small words are just absolutely tiny. Which will show what you think the priorities are for us to work through at this conference. So the biggest work is action, which is, I think that's the one that most of you have said, which is good to see. So you all think we're ready to move beyond describing and admiring the problem, and we at Natural Voices couldn't agree more. We had a brilliant chat from Bola, who was the new director of inequalities at NHS England recently at another event, and she said very clearly we need to stop describing the problem, or just describing the problem, and need to move towards saying what's the first thing we're going to do now. And then the other big words are collaboration, which is obviously also music to our ears, because we do believe that we do need to bring together the assets and the different ways of working and the different cultures that come from, let's say, how the VCSE works and how the statutory sector works. That's a very obvious collaboration we need to get right if we want to tackle inequalities. But there's also something about the different cultures within the charity sector. There are very grassroots, very community-based organizations who are not very professionalized, if you want to use that language. And then there are very professionalized organizations who sit on very big assets, lots of staff, big fundraising capabilities. And we do believe those organizations need to collaborate in order to get to people the large organizations can't get to on their own, and the small organizations can't achieve everything on their own. So we think there is a real need to get that right. Solutions is another really big one, which is sort of in the action space, isn't it? Advocacy, accessibility, equity, listening, understanding. We will collate all of this and share it with everyone and use it to understand how we need to shape up the agenda going forward. I'm now going to hand over to Bibby from the Health Foundation, who is talking about their work on reframing how we think about the social determinants. Thank you.
Great, well, thank you very much, Charlotte. So I'm Bibby, I'm the Director of Health at the Health Foundation. And as Charlotte says, one of the things we've been thinking a lot about is how do we shift the way the public thinks about health inequalities so that we have more support for action. And I'm going to share some reflections on that. And to do so, I do want to share my screen and share some slides. So when we had the prep talk for this conference, Charlotte kind of said, why is it when we're all good people and we know what needs to be done, we haven't made more progress on health inequalities? So I thought, well, that is a really good challenge. And my reflections on this is I think there's 4 questions we need to be asking ourselves. And the first question is, do people know about the extent of health inequalities in this country? And I would say from the work we've been doing at the Health Foundation over the last year and a half, where we're going out and talking to different sections of the public very purposefully about their understanding of what makes us healthy and what leads to inequalities in people's health. Whereas this kind of chart is something we're all very familiar with, it really is not something that's so familiar to the public more generally. And the other thing that's quite interesting, I think, is that on this chart you can see the end of the red lines are reflecting the differences in life expectancy by deprivation. So there's a 10-year difference in life expectancy between the richest and poorest 10% of our country. But the blue line stops at the healthy life expectancy. And when you look at that, that's where you see this much bigger 18-year difference in healthy life expectancy between the richest and poorest. And what I found quite interesting is that people, when they are familiar with some of these things, are more familiar with the life expectancy, the healthy life expectancy difference really shocks them. And kind of not surprisingly, when we live in a country with a universal healthcare service, it is something I think that challenges people. So I think this is an important thing to hold on to. The second question I think we need to ask is, do people care? So even if they know about, or when they know about health inequalities, do they actually care? Now, I think there's a sort of bit of a mixed picture here. And one thing I just wanted to draw people's attention to, if they didn't see published last week, was the piece of work that King's College have done for, as part of the Institute for Fiscal Studies detailed inquiry into inequality in Britain. And they've been surveying British people's attitudes to inequality in the light of COVID. So this is inequality generally, not simply specifically health inequality. And I mean, I think when you read this, it's quite sobering reading. The inequalities people are most concerned about are inequalities that arise from where we live. So inequalities across the country geographically. And around 60% of people think this is a problem. But I think when you look at the data about the differences in race and ethnicity and inequalities, only 40% of the population are highlighting this as a concern. So I think, this is not comfortable to know, but it's something we need to know and we need to understand, and we need to be kind of working with this information. So if you haven't seen that report, I'd really recommend seeing it. Now, the other thing that the Health Foundation is doing at the moment is a COVID-19 impact inquiry, where we want to understand how the health of the population as we came into the pandemic and the impact of what happened during the pandemic is going to play out in our health longer term. And as part of that work, we're doing a series of engagement work across the UK with different people. And the sort of initial survey data that's been produced to look at that, people's attitudes, highlighted essentially 4 groups of people in terms of their concern, understanding, attitudes towards the inequalities that we've seen during the pandemic. And the 4 groups are actually split fairly equally, but one is there's a group of people, like all of us, who would be classed as activists. So we know there's a problem, we want to see something done. There's a second group of people who are termed as recognisers. So they recognise the problem, but they probably think it's all a little bit too difficult. Like, where do you start? It's overwhelming, it's poverty, it's these big things. The third group are disengaged. They know it's a problem, but they just say, well, that's life. It's always been like that. Why is it going to be any different? And then the final group are the skeptics, who don't think there's a problem and therefore don't engage. Now, I think really starting to understand public attitudes in these different ways is important if we want to take this discussion to the public and get support for change. And a really interesting example, again, from the Royal Society of Arts, who have been doing work on public attitudes to poverty, is what they've found is that when you talk to people about poverty, that actually often that phrase is something people, they think more about destitution. They think about the acute end. They don't think, as Michael was saying, about working families not able to get to the end of the week. So they don't recognise poverty so much. When you talk about inequality, they just think this is big, it's too big. But actually what RSA is starting to talk about is insecurity, because they say this is something that everybody can recognise. It's a more familiar framing. So moving on then, if people know, if they care, do they buy into the strategies that need to happen to address health inequalities? And we've got some little icons here of all the things that Sandra and Michael were touching on, of the things that make a difference to our everyday life. And when we've been doing these workshops with people online around the UK, and we present this to people and we explain how these are the determinants of health, it's actually really encouraging. People make those connections, they make sense, they're very real to people. However, the thing that then is not quite so encouraging is when we say to people at the end of the session, so where do you think the government needs to be investing? We've talked about poor housing, we've talked about lack of education, poverty. We say, where do you think the government should be investing? They say the NHS. because we have this thing in this country where we associate, you know, the NHS as important as it is for us when we're ill. We also think it's what makes us healthy. But as Michael's work shows, and as Sandra's experience describes, they're very different things. So finally, I think the question we need to consider is, does the government have the right incentives to do something about it? Now, I think there is actually a silver lining here, in that for the first time, we have a Conservative government that actually has some of the places with the lowest life expectancy and the highest levels of avoidable mortality as their constituencies. So this is a chart that we put together at the Health Foundation after the 2019 election, and the purple line at the top is the ratio of excess mortality from inequality, so avoidable mortality relative to the population. And what you can see, that purple line, are the Conservative seats that were gained from Labour, and that's where the highest ratio of excess mortality is relative to the population. And then Labour seats, which probably doesn't surprise us. And then if you look at the traditional Conservative seats, you know, they're the places where people are more healthy. So it's not been surprising maybe that in the past this government hasn't prioritised the agenda. So I think we have an opportunity here. We have a government that has constituencies that they have to pay attention to, where these are very real. And then the final thing that I'd add is that just before Christmas, and it's out of consultation at the moment, and in fact closes tomorrow, the government published a health index for England. And this health index takes into account what we know about people's health, individual health, what we know about their lives and whether it supports them to be healthy, and what we know about the places they live. And it's not perfect, but it kind of creates a very different platform for conversation than we've had previously. So I think in conclusion, if we're really going to get the change that we all want, the action that we all want and saw on the word cloud, we have to find better ways of getting this evidence out to the public. We have to explain to the public why health inequalities are bad, not just for us as individuals, but for us as a society. We have to be able to explain what makes us healthy, that it's much more than the NHS. And then finally, we really need to make sure we're kind of pulling on those levers and incentives for the government to act. So thank you.
Thank you so much, Jo. So interesting. It's always good if someone goes back to the data. Really interesting. I'm particularly struck by thinking through how we could frame some of our arguments as being about insecurity, as something that connects maybe more of us than just thinking about poverty or thinking about inequality. I think that is definitely worth unpacking a bit more, isn't it? But also, you know, the connection with the seats that recently moved over to the Conservative Party, there's a political opportunity here, definitely, isn't there? So I think we will return to that in the Q&A, because some of you are asking questions about the relationships between politics and the NHS. And I think an interesting question is also the relationship between charity and politics, which is like, you know, never that easy. So before we get into the Q&A, we do another word cloud, and this one's about what do you think is the main barrier to the VCSE? And for those of you who think that's all jargon, let's call it the charity sector. What do you think is the main barrier for the charity sector to tackle health inequity effectively? And I think there's some things that have already popped up in Sandra's talk, and Sir Michael's talk, and in Jo's talk, to reflect on. Why is it difficult for us as charities to do this and to do it well? So I can please encourage you to go on to the Mentee Meter, which I'm hoping Laura will now share there we go, there's the link. And you can go on there and do the same thing you did earlier, and I encourage you to do so. I have been watching the chat and the Q&A, and there is a number of questions that jump out at me. I'm going to ask a question of you each, and I'll announce it now so you can have a little think. I'm going to ask Sandra what she thinks we can do, not necessarily the person with the ill health, but what services and politics could do to reduce stigma. You know, what's not helpful? What are we saying to people that makes them feel that they are to blame for what's going on? I would like Helen to have a think and maybe talk to us about how do we think, and you know, these NHS reform processes that are now being kicked off again with yet another white paper, yet another restructure of the NHS. Is there anything in there? Can we give this an inequality bend? What do we need to be mindful of to get this right? Particularly some people were asking about the ICS level, what's there around the inequality agenda. And then Joe and Sir Michael, there is a number of questions about politics. How are we going to tackle the politics? And maybe connected to that, why did we choose to call this, or why do you choose to call your work as being about inequity rather than inequalities? Maybe you could say a few words about that. So, Sir Michael, do you want to kick us off? Why inequity rather than inequalities, and how are we going to grasp the political nettle?
Well, we've in Britain traditionally talked about health inequalities. When I chaired the World Health Organization Commission on Social Determinants of Health and looking at inequalities in health globally, I put on the cover of our report, social injustice is killing on a grand scale. And influenced by colleagues at WHO, inequity gets at the idea that the inequalities that we see that are judged to be avoidable by reasonable means and are not avoided are unfair, which is why I called my 2010 report Fair Society, Healthy Lives, and called my late 2020 report Build Back Fairer. So inequity gets at the idea of inequalities that are unfair. And that's why my institute is called the Institute of Health Equity, actually trying to look more positively, not health inequity, but health equity. That's what we want to achieve. As to the question, how do we engage the politicians? A senior politician asked me that question recently. He said, we're nice people, and we're somehow not taking the public with us. What can you advise us? And my response was, one thing that age and experience teaches me is the things that I'm good at and the things that I'm not good at. And I'm not good at telling politicians how to frame the argument. You'll come to the wrong person. I can tell you what I do. Number one, tell the truth. That would be a change, wouldn't it? That would be a radical change. Now, maybe they're too scared to tell the truth because it makes them look bad. But number one, tell the truth. Number two, speak from the evidence. So although I talked about concepts this morning and attitudes, I've got good evidence to support that change in attitudes that I talked about. And third, I said, engage people in the kind of society we want. So the question should not be, how do we get economic growth, or how do we help the business community, or how do we get the welfare bill down? But what kind of society do we want? Engage people. And my guess is you can engage people from Sunderland to Surrey in that conversation. It's what unites us, what gives the best opportunities for all our children to have lives of dignity. So no, I don't know how to tell politicians what to do, but I do know, I think, how to engage people of good faith in a conversation about the kind of society we want.
That's wonderful, thank you. And I agree with you, we need to focus on what we're good at. Joe, I do believe you have done some serious thinking about how we're going to engage politics with this and wider society, but also maybe your reflection on inequity and inequalities briefly. Over to you.
Well, I think I'll focus on
You're on mute, Joe.
Yeah, how we engage the politicians first. In my presentation, as I was saying in my can you hear me?
Your connection isn't great. Yeah, All right, you go.
Okay. Is that better now? I'll try for a moment, but tell me if it's not working. Okay, I think we really have to start with public attitudes. I think, you know, politicians are elected by the public. They do follow what the public concerns are. If the public isn't articulating a concern for this, then it's not really surprising that it's not on the top of the political agenda. But as I said, I think things might be changing. So I think there's some opportunities. I think the other thing is we mustn't underestimate how little people know about some of this. We're all steeped in the evidence, you know, the experiences. It's something we're familiar with. It's not something that, you know, the majority of people, I think, engage with and understand. So we really have to be explaining more, not taking for granted. I think the other thing is that, you know, there's not going to be a quick fix to any of this. It will take a long time. So sometimes I think you just have to take the opportunities that are in front of you at the moment. So if a particular government is deciding they're going to work on one aspect of this, well, you know, let's really make sure they do that in the best way, which, you know, let's really maximise the action they take there, you know, and, you know, another government will come along with other priorities. So I think, you know, there is something about seeing this as a long-term endeavour, sadly, that we have to do. On the difference between equality and equity, I always think of the cartoon, which I'm now sort of getting a bit stuck remembering. But I think, as I understand it, the important thing about equity is recognising that it's not treating people equally because people have different starting points. So you've got to make sure that you are removing any barriers or providing the additional support that individuals need to have an equitable outcome rather than just giving them equal opportunity. So I hope I answered that.
Thank you so much. And I've just been following the chat and someone says, and I think they've got a point, that inequality is already a language that can put people off, and they feel inequity even more so. So whilst I totally take the point that it makes a clearer connection to justice, it just also feels, I think, like even more technical language. And it's not how people describe their lives. So I think that's a challenge we have to bear in mind if we want to take the public along with us, is that inequity is a word that no one in everyday parlance uses, and it might even be off-putting, I don't know. But I totally take your point that it makes a clearer connection that it's inequality that's not okay. Sandra, over to you. What are your thoughts on what collectively and politically and as a health service we could do to reduce stigma?
But I earlier spoke about how my own mental health stigma stopped me from accessing mental health services at a much earlier stage, which would have, if I had, I would not have seen a much more, my condition would not have worsened, to be absolutely correct. But I think there should be a lot more about awareness, that members of the public should be made aware of this stigma, and stigmas that it's just not, like for me, it's just not the mental health stigma, but stigma can be poverty, stigma can be, you know, lack of education, you know, awareness. So how do we work together with members of the public, the communities, the charitable organizations and social care providers? How do we work together to actually let people know that this could hinder your accessibility to healthcare, and also how you can actually manage your own healthcare as well, manage your own health. So it's important to talk about stigma more openly and widely. For instance, some of the communities do not talk about stigma, do not understand the meaning of stigma, or it's not even something that is important to them because their day-to-day life is much more important managing that than to think about the word stigma. But from my own experience and from experience of other people that I have encountered or had communication with who have had mental health illnesses, talk always about the stigma that has stopped them from accessing the services.
Thank you, Sandra. There is a lively discussion going on about language, which always gets people exercised. People like unfair and fair, it seems to me, and justice and unjust. And I think that is also pause for thought. I wonder whether we should go out to some posters and ask them what works with the public, but maybe someone's already done that. And then there's also quite a lot of questions on intersectionality bubbling up in the question and answers around, you know, gender obviously overlays a lot of that. One thing that the pandemic has also shown is that, you know, women have been really hit very hard with job losses and looking after children at home and all the rest of it. I don't think I'm going to unpack all of that right now. I'm going to hand over to Helen to tell us what she thinks we can expect or not expect from the upcoming healthcare reforms. How can we give them a health inequality bent?
Thanks, Charlotte. I think most people, if either know me or you've read my bio, you've seen that I've spent most of my career in the NHS, both at a local level and at a national level. And one of the things that's really taught me is that in the NHS, what gets measured gets done. So the NHS is very good at taking a target and putting all its efforts behind achieving that target. So there's something for me about, as ICSs develop, and ICSs, you know, integrated care systems, they are about bringing together organisations within the NHS and across wider civil society. There's something about the importance of the conversation around that ICS table, and possibly even more importantly, the conversation between the people around the ICS table and those in NHS England and the Department of Health who are holding the ICSs to account. If we have conversations which are all about waiting time targets and money, waiting time targets and money are going to be what gets delivered. Now, they're not unimportant, but if we have conversations which are about inequalities and equity and really understanding what it is that the ICS is doing to meet people's needs, we may find that we are in a better place to address those process issues, if you like, the waiting times and money, as well as looking at health inequalities. So there's something, I think, and picking up on what Joe was saying, there's something about understanding the politics, and short-term and political issues are a reality of life. They're not going to go away. But I think if our ICS leaders and if colleagues at NHS England and the Department of Health and MLCG as well, local authorities, have in their minds and very clearly at the forefront of the conversations that they're having with local leaders, the bigger picture and the need to address health inequalities to improve the experience for all, then what we can do is we can think about how we meet the short-term process targets as well as that bigger picture. So I think there's something for me about people being able to hold both the short-term and the long-term in their heads.
Thank you so much, Helen. There's obviously so much more we should and could be talking about here. Just now, I think in the chat, people are talking about mental health stigma and the connection between mental health and adverse life experiences. And we have 2 sessions this afternoon which look at this in a lot of detail. And we chose those because we do think, from our perspective as charities who are always in the practical space largely, mental health is one of those gateway topics that a lot of other inequality follows from. So people who are low mood or fatigued or depressed obviously find it so much harder to, in conservative parlance, make the right choices. So we do think that's one of the ways we as a sector can get upstream, is for charities that look after physical health problems to also think about mental health much harder, because obviously that is very much loaded towards people who had adverse life experiences and are struggling with poverty and discrimination and exclusion. Right, we're not going to be able to do all of this in these 60 minutes. So before we wrap up, we're going to look at what you thought the VCSE needs to tackle in order to play a role in this. And this is, we're doing this through another word cloud. So Laura, if you want to bring that up. Again, those are very small words. Okay. Oh my God, I hadn't thought of funding, but of course funding always comes up when you ask the VCSE any question about what do you need. And you've got a point, to be frank. And I think there's obviously something about the overall funding levels in our sector, but I think there's really something about, if we want to go more upstream and want to tackle the causes of the causes, we can't work with funders who want to see results in 3 months. That's just not going to work. So grant programs that say to you, here's 6 months worth of funding, and then we want you to have cracked childhood obesity, is obviously laughable. So of course we then end up doing, you know, an exercise, a walking to school thing, you know, that you can do that in 6 months, but you can't deal with the causes of the causes. So I think that is really interesting. I think resources is obviously connected to funding, lack of funding. Someone else said there's a lack of intelligence in the system because it could have pulled these things together. Other big words are competition, education, politics, evidence. The competition piece, I think, is interesting. What's driving the fundraising model sometimes in charities can be over-claiming what you can achieve on your own. Again, that's something I think that's sometimes funder-driven. You know, we asking you for £25,000, and with that we're going to deal with discrimination, poverty, lack of literacy, and high blood pressure and mental health stigma. You know, and it's like, we have to almost pretend we can crack everything on our own in order to get through the funders' doors, rather than funders saying, how can you partner up more intelligently with other people? So I think there's something there. Scale and capacity is popping up. And I can't actually read all the really small words. Sorry, that's probably my age. We will obviously make these bigger and share them with you so that we can, because the one thing that struck me about this word cloud and the last one is that the diversity. So there's obviously, we're not all on the same page. We have different perspectives on this, which is hardly surprising. Right, we're coming to the end of today's session. So I'm just gonna thank you all for attending, and then particularly obviously thank Joe and Sir Michael and Sandra. But I'll hand over to Helen, who will wrap us up. And Laura, if you can show the last couple of slides for that as well. Thank you.
Thank you again, Charlotte, and thank you to everybody. I too have been keeping an eye on the chat and the questions, and there are some fantastic ones which, you know, we haven't had time to do the lot of them justice today, but we have got, as Laura's showing us now, we've got another 4 weeks or 4 Tuesdays of sessions, and I hope we'll be able to get to many of them in that time. All the questions in the chat we will hang on to, we'll be looking at in National Voices, and if we can't address them in the next few weeks, we will certainly build them into our work programme for the coming year. I think just reflecting on the last hour, overall, I've been really struck by the need to reframe personal responsibility. It is not the responsibility of the people who have the problem to fix the problem. It's a collective responsibility for society. But I am conscious that when we describe something as everyone's problem, it can too easily become everyone else's problem. You might possibly have spotted me turning my camera off for a minute about 5 minutes ago. I went to go and find my John Donne, because I'm really struck by what John Donne said. You know, no man is an island entire of itself. Every man is a piece of the continent, a part of the main. Any man's death diminishes me because I'm involved in mankind. And I think one of the things that we can do, and we can build on COVID to do, is to build on that sense of community that has been created by COVID. It may not be everywhere, but it is much stronger, I think, than it was before. And we need to build on that before people forget it, before people want to put this year behind them as an awful experience, to help people hang on to the positives that came out of it, and to use that to build on the work that we need to do to address the inequalities that underline so much of what we saw this year. There is so much that I could comment on from all our speakers, but I think I'm just going to finish with some of the words from Michael, from the last things that Sir Michael said. We need to tell the truth. We need to hold that mirror up to people. We need to use the evidence, and we need to engage people in these conversations. So in doing that, in closing this morning's session, again, to thank you, to thank Health Foundation and PPL, and really invite everybody to participate over the next few weeks and help us agree the actions that we can take as National Voices, that our members can take, and that we can work with the NHS and the wider civil society, the wider public sector, to address health inequalities in the coming years. Thank you again so much.